name is Shyam Patel. I'm an assistant professor of medicine within the Division of Hematology Oncology at UMass Chan Medical School. Today, I'll be discussing our recent study on the natural history of clonal hematopoiesis in real-world clinical settings. As you know, 10 years have passed since the initial large-scale descriptions of clonal hematopoiesis, which were performed by a variety of centers. And clonal hematopoiesis is thought to be the pathophysiologic hallmark of myeloid neoplasms, and it's a precursor for the myelodysplastic neoplasms and acute myeloid leukemia. Typically, the rate of progression on average for CHIP to MDS or AML is about 1% per year. But last year, we've seen excellent data from the New England Journal of Medicine Evidence Journal from 2023, suggesting that there is a refined prognostic risk based on the clonal hematopoiesis risk score. The clonal hematopoiesis risk score was a method that was assessed for patients from the UK Biobank from Healthy Consortia. In our study, we sought to perform a similar analysis in the real-world setting for patients who actually presented with an indication for testing in the first place. So these patients were people who had cytopenias or who had an indication for testing, such as having fatigue, night sweats, weight loss, or other hematologic specific symptoms. As we know, recursive partitioning of healthy consortia led to the development of the clonal hematopoiesis risk score for clonal hematopoiesis. But in the practical setting, most cases of CHIP and CCUS in the current day are diagnosed only after patients present with hematologic specific symptoms. So to address this real-world population, we annotated our UMass leukemia registry, which contained patients who had DTA or DNMT3A, TET2, and ASXL1 mutations against true clinical diagnoses of CHIP or CCUS based on the international consensus classification and the WHO-Hem5 definition. In brief, we found that a total of 94 patients had true diagnoses of either CHIP or CCUS, and we segregated these patients into patients who had sole DTA mutations, that is, mutations only in DNMT3A, TET2, and ASXL1, or the canonical CHIP mutations, compared to non-sole DTA mutations, or patients who had mutations in any other cluster that was not purely DNMT3A, TET2, and ASXL1. We mapped the clinical trajectories of these two groups from the real-world setting, and we found that for patients who had sole DTA mutations, they did not progress to an obvious myeloid neoplasm in the absence of an additional mutation. In other words, a concurrent mutation or mutations were required for progression of sole DTA patients to myeloid neoplasm. This was not true for the non-sole DTA group, in which case non-sole DTA mutations were actually sufficient for progression from CHIP or CCUS to MDS or to AML. We also validated the clonal hematopoiesis risk score in the real-world setting. And as we know, the original data from the UK Biobank showed that the clonal hematopoiesis led to the clonal hematopoiesis risk score, which was an excellent model for prognosticating CHIP and CCUS. In the real-world setting, we found that patients who actually did progress to myeloid neoplasm had generally high-risk CHRS, whereas there was a lower frequency of patients who did not progress to myeloid neoplasm who had high-risk CHRS. There was a great correlation between the CHRS score and true progressors in the real-world setting for patients who had an indication for testing in the first place. On individual gene analysis, we found that the RUNX1 mutation carried the strongest risk for progression from CHIP or CCUS to either MDS or AML. Overall, our study provides insight into patterns for progression to myeloid neoplasm and may be very valuable, and it may be very valuable to use the CHRS in real-world hematology settings. Thank you very much for your time.